We're off and recording. So again, I'm Tommy Winston, serve as the program coordinator for the PTA program here at MCC. Prior to coming to MCC, I worked in a number of different settings in physical therapy, primarily outpatient orthopedics, spine rehab, a lot of pain management, a lot of spine care rehab, post-op spine. I also worked in long-term acute care. I worked in general acute care, skilled nursing facilities. I worked in rehabs. The only setting I have not invested any time is home health. So I'll be transparent there. I have not been home health. Not that there weren't opportunities, it just was never my thing. I like for a patient to come see me. I don't know if I have the heart to torture you in your own house with the prices right on. It just feels weird. Come on, little old lady. Bob Barker's on TV screen. Just feels bad. So don't think I can do that. So other than that, we have a good time over there. I have been tasked today with trying to demonstrate to you range of motion activities as it relates to what you will be doing as it relates to your profession, and transfer skills, ways that you can help your patient move about easier and hopefully safer. So that's one of the things that we will hopefully be able to do. Anybody have experience performing range of motion activities already, either with patients or with friends or family? You're skilled with transfers. You go, I really should be teaching this class and not this idiot that's standing here. Nobody? Okay, good stuff. Good stuff. Nobody feels like they are overly knowledgeable yet. But I pray that by the time you leave, you will have tons of knowledge. Okay, I'm a volunteer kind of guy. I also like feedback. So don't feel like you're just gonna be able to just sit here and stare at me like it's a movie. When is he gonna do this? Really? No, so I like feedback, so talk back to me. I also love volunteers. So give me a volunteer, we'll get started. Come on down, I don't bite, at least not on Tuesdays. Thursdays is a rough day, I'll bite on Thursdays. Today's Wednesday. There we go. All right. On your back for me, lay on up here if you don't mind. Okay, what's your name, man? Megan. Pleasure to meet you, Megan. Okay, so we will discuss ways to perform range of motion. For the most part, in a hospital setting relating to nursing, the types of range of motion you will be asked to do for the most part is going to be on non-orthopedic patients, meaning these are not post-op surgical patients, post-op total knees, total hips, total shoulders, where they're asking you to go in and do range of motion for that. These are going to be general health patients who may not qualify for PT because they're low level. They have diagnoses that would not allow us to come in, or they have mentation levels, or their level of consciousness is so low that they're just not safe for us to move about as it relates to therapy. So therapy has to be what's called a skilled service. So general range of motion is not something that payer sources consider skilled, meaning, in simple terms, if the hospital can't get paid for it, they're probably not going to allow us to do it. Ultimately, we just have to be transparent about that. So it will be general motion patients, things that you'll be able to do to move them through ranges of motion to help keep them mobile as their overall health status is improving, so that they can qualify for the minimal basic level for PT to pick them up if needed. So we'll talk about that. The good thing about range of motion is the body is set up to move. As you all, I'm sure, have already learned, the body it's not two different types of skeletons, but two functional variations of skeleton within it. So you have your axial skeleton. That's going to be the cervical spine, the head, the thoracic spine, the sacrum, the pelvis. Those things consist of the axial spine. The extremities, arms, legs, those are called your appendicular skeleton. they are going to be synovial joints designed to move. So it's okay to move them as long as they don't have contraindications to moving, we can move them. So that's the great thing about that. They're designed to move. Patients may be fearful, patients may be in pain, but it's still your job to help comfort them, let them know that you're not there to hurt them, but you're there to make them feel comfortable and to help their joints move because, and this is the reason why we like range of motion. Anybody know why? Say it again. We're meant to move. I agree. Neurophysiology. Anybody? No, that's not the answer, but I'm asking for neurophysiology. But it sounds good. It sounds like I'm smart, doesn't it?
It does.
I have no clue what I'm talking. I make this stuff up on the run. Anybody? Okay, so let's talk about why movement is so important. So range of motion is really important because at the end of your joint's range of motion, when you get a joint to its full range of motion, it stimulates a part of your spinal cord called the alpha motor neuron, and it sends a signal to it to tell it to turn off and allow your body to relax. So getting a patient to their end range of motion actually helps the body to relax. Have you ever noticed when your muscles are tense and tight, you can't relax? If you're stressed for a test, everything is tight. Somebody walks by you and they touch your shoulder, they go, good God, you're tight. Don't touch me, I'm fine, trust me. So the tighter you are, the less you're able to relax. So if we can get them to end range of motion, we stimulate the alpha motor neuron and it actually turns off the signaling for stress and for pain sometimes. So it's actually a benefit. So let's walk through this and talk about range of motion. So we're going to deal with upper extremity, we're going to deal with lower extremity first. I'll give you a break, then we'll come back and we'll talk about trunk and transfers. That a deal? I won't keep you forever, I promise you. I'm long-winded, but I won't keep you all day. So let's talk about extremity range of motion. We'll start with the glenohumeral joint or the shoulder. The first thing I always tell people about range of motion with shoulders, proximity matters. So if I'm doing a stretch activity, and I'm out here and I'm just holding her arm, do you feel safe? You feel like I really care about your arm? If I'm getting ready to move it, it hurts, doesn't it? You don't even like this, and she's not even painful. So if you're grabbing somebody's arm, getting ready to move it, and you're way out here, and you're not focused, and you're, all right, this is John, we're gonna move your arm, you whack on, you slam it back, that patient's not gonna wanna see you again, and they probably wanna kick you. I would wanna kick you. So, the first thing we wanna teach you, proximity matters. So when we're doing range of motion, we wanna be near our patient. It's okay, get on in, they won't bite. I promise you, patients like you being close to them. Support the extremity with your body, and then hold it with your extremities. This is so much more comfortable to the patient, and it gives them a sense that you're in control. So, okay, see, she doesn't even feel like I'm gonna lose her arm. She doesn't feel like I'm gonna hurt her. She's so relaxed. She really has let go. She just let me have her arm. So it's so flexible. I thought I was joking. She's relaxed. Positioning matters, proximity matters. So get in close to the patient, have great proximity. So if I'm going to move the shoulder into, so the directionalities of the glenohumeral joint, it has the ability, it has 3 degrees of freedom, which means it can move in all of the planes of motion that a joint can move. It can go into flexion above the head, extension behind the body. It can abduct up to the side, adduct coming down. It can internally and externally rotate. And there's a lot of ways we can do that. This is a type of internal external rotation. So is this, so is this, so is this, and that. So there's a lot of things we do every day that rely on internal and external rotation. So we'll walk you through how to do all of those strategically for a patient. So if I'm going to do shoulder flexion, again, I'm going to get close to my patient. The first thing I'm going to do is adjust the height of the surface that I'm working on. So even before I grab the arm, I'm adjusting the height of the surface. So let's see here. Whoa, Jesus, almost lost you there. Whew. Hang on, there we go. So let's say we're working together. She's my patient, and I come in and she's at this height. And I'm going to grab her arm, and the first thing I do is this. And I'm holding her here, and I'm bent over, and we're just working. I'm still doing what I'm supposed to do, but I'm in this position, and we're working. What problems do you think that poses? Your back. That's right. You're going to end up breaking your back and end up paying me. Thank you. My mortgage payment is due, in case you just want to. I have a fund, Save the Winston Fund, if you just want to give me money. But other than that, don't injure your back. So the straighter you are as it relates to your posture, the better you're going to be able to help people do the things that they need to do. So always start from an appropriate height. Get people near your waist or higher if it's available. And most hospital beds will allow vertical movement. So it's not like we don't have the option to do this, but sometimes we get so busy and so caught up in doing things, we forget basics. So don't forget the basics. This takes a while, sorry. It's not you. It's me. Here we go. Whee. It goes down a whole lot faster. Okay, so appropriate height, that's number one. So that I can have the extremity near my chest, and so that she feels comfortable. So the first thing we'll do is flexion. So I'm having the extremity here, and what I'm going to do is I'm going to start to walk her into flexion. I am not using my arms to do any of this. I'm not doing this. I'm using my trunk in my legs with shifting side to side to do the work. So let's give you an example. When I do flexion, I have her here. When I go into flexion, I'm going to lean my body into the movement and allow her arm to go back. All of this is happening with my trunk shifting. So I'm holding and I'm shifting my trunk, coming back, shifting trunk, coming back, shifting trunk, coming back. The reason why your leg muscles are twice as large and you have more mass than your arm muscles. So this keeps you from wearing out doing this for long periods of time. So I'm holding her here, I'm moving her, but my body is not doing any of the work. It's my arm is not doing any of the work, just my leg. So I love that. Now, with most patients, the main thing you have to check for with flexion is once you get to about 100 degrees or to the level of their face, you need to make sure that their scapula is also moving. So you want to reach behind them if you can and make sure that the scapula is coming with the arm. So the scapula, when I'm moving my arm, has to abduct and upwardly rotate. It has to do this. It has to tilt up and rotate. So I need to make sure that my scapula is doing that so that their arm gets full motion. If the scapula is stuck, no matter how much the arm wants to go, the scapula is going to limit. So let's prove it. Give me another volunteer real quick. Come on, just go on up. I won't wipe, I swear. So let's prove this point. This is a cool point. Okay, we didn't practice this at all, right? You're not a paid actor. So let's start with shoulder flexion. Go as high as you can go. Good stuff. So we agree, it's good motion, right? Not bad at all. Great motion. So that's no, okay. Anyway, now I'm going to turn her sideways toward you guys. I'm going to hold her scapula into her body. That's all I'm going to change. I'm going to lock her scapula. Now, lift your arms for me, ma'am. Wow! Damn, what happened? It doesn't move, does it? Try one more time. So that's as far as it goes. Same difference. Let's prove it to the whole class. Okay? Everybody, while you're sitting, raise your arms as high as you can go. Good stuff. Look at that. Beautiful. Now what I want you to do, bring them down. Now, round your shoulders as far as you can round them. Hold that position. Now raise your arm. How did you go? Don't move. Look at that. We just made all of your arms 30 degrees shorter than they were before we started. Quickly. That's amazing. So posture has a whole lot to do with it. Scapular mobility has a lot to do with arm motion. So if we aren't making sure that the scapula is coming with it, we'll hit a hard block of 110, 120 degrees, and we don't think that's all the motion that they have. The patient will scream, well, ow, that hurts, when really all we need to do is just grab the scapula and just bring it towards us. So you're just grabbing the medial board of the scapula and just walking it towards you to make sure it frees. If needed, most people's arms won't need that. But if you find yourself hitting a hard block here at 110, 120, it's probably the scapula not moving and not so much that the arm is bad. Make sense? Yes. Good stuff. So I'm holding in, I'm walking her, we're going into in-range flexion. She's comfortable. I haven't broken her yet. You okay? Mm-hmm. I'm just trying to get it as far back as it will let me go. Nothing aggressive. I'm not forcing the arm. I'm just letting it drop as far back as it will let me go. I give a little push at the end to get the in-range motion. So that's shoulder flexion. Questions?
How come when you do that, it feels like my arm, like, I don't know if you could feel it like vibrating, like it feels like
It's trying to gain control back from me because it's not used to being moved at the end and not having some control with it. So it wants to help. So that's that fasciculation motion you're getting at the end.
So this is all passive range of motion, right?
Right. So, and you can invite them once you know how far the joint moves. I can move quickly through all three types of ranges of motion. So first thing I would do is passive, see what the joint will do.
Okay.
Move right into active assist. Okay, the joint moves. All right, now I want you to help me move. All right, so we're moving together. That's great. You're doing wonderful. Okay, now I'm going to help less. Now you move. I'm still going to support, but now let them do all of the range.
Okay.
So I can move through all three simultaneously really quickly. So that's the good part about this. Good question. Next one we'll do, shoulder internal external rotation. So I'll bring you over this way for me. No, just scoop. Everything will still be on the line surface. So for this one, what I like to do is let their arm rest on my knee. So for those who don't see, let me turn this way. So I let her arm rest on my knee here so that her arm is relaxed, still in control of the motion. I'm not way out here. Okay, we're gonna throw your arm back and forth and see how it works and pray it doesn't come off your body. So I wanna keep it tucked into me, keep my body tucked into the bed near her, holding down on the shoulder, because moving the shoulder into internal external rotation can actually displace the humerus, especially if there's a lack of musculature or a lack of joint capsule there. So I want to kind of hold the front of the shoulder, and I'm just walking her into this direction. Which direction is this? Anybody? External, yeah. So external rotation. There. So I'll just walk you there. Just letting the joint go as far as it'll go. Nice and easy. And if I wanted to make it more active, well, active assist, so push down for me. Good. So we active assist. And then I can go right into full active range. Okay, just pull back. Good. Okay. Then all I do to get to internal rotation, switch my position. Coming around, holding from this side, same position. Now I'm just going to walk the arm into internal rotation. You really want to kind of hold your hand on the head of the humerus so that the arm rotates in and the humeral head doesn't pop out and forward. So it's stability for the humeral head.
Have you ever had that happen?
Never, because one thing we teach always, and you're always taught, anytime you do a range of motion with internal rotation, stabilize the anterior units. So we've just been taught that so many over the years, it's almost second nature.
Okay.
But it can. You can dislocate a humeral knee with motion. It's rare, but anything is possible. And so just dropping her down, internal rotation, yay. Yay. Okay. All right, then scoot back on for me there. We're gonna get y'all almost off. Okay, any questions? Internal, external? Feel okay there? Next one we can do, abduction, similar to flexion, locking her in with my body, holding her arm out. I'm going to stabilize her arm against my body, holding on her shoulder. And again, I'm taking a step, moving her into shoulder flexion, or excuse me, into shoulder abduction. Let me come around this way so people can see it easy. So I'm supporting her here. I'm facing the opposite direction that we're going. And now I'm going to move with her as she's going into abduction. Again, all the work is done through my hips. None of the work is done through my back or through my arms. My hip is doing all the motion. And I can let it come as far up as it'll go. Okay? Adduction is a motion we really don't have to stretch. As long as the arm comes back and rests at the side, it has general full range of motion in adduction. Okay? Any questions? Okay, so it's flexion, internal, external rotation, abduction, adduction. The last other motion we need for the shoulder is extension. Now, extension is hard because we need the arm to go behind the body, but the patient is supine in the bed. So it's kind of weird. How do you do that? Could put them on their side, absolutely. That's really the best way to do it is put them on their side. Another way, I'll give you a cool thing you can do, and you can actually get a 2-for-1 with elbow extension and shoulder extension. Have them scoot towards the edge if they can scoot, if you can get them. And what you'll do is rest the arm off the edge of the bed and then just go into some shoulder extension. So bring your shoulder off, just there you go. And now, right there. So now I'm getting shoulder extension. So she feels a stretch here, correct? And I'm also getting elbow extension at the same time. In this position, I love more than just sideline for one main reason. One of the muscles that tends to be tight on patients or tend to be overworked or certainly problematic, especially if we have what's called upper motor neuron symptoms, post-stroke, traumatic brain injuries, anything upper motor neuron, we end up having tight elbow flexors or biceps. So if you ever watch stroke patients, for the most part, they're held like this or like this, but the arm will always be adducted and the humerus will always be flexed, or the elbow will always be flexed. So this is a good way of stretching those elbow flexors because they attach not only to the shoulder, but to the elbow. So by getting extension this way, I'm stretching a 2-for-1. So not only stretching the things in the front of the shoulder and getting range of motion going in the posterior direction, but I'm also stretching muscles that tend to be problematic over time. Because most people are going to lay there in almost a flexed upper extremity position. So, okay, come on back on. Thank you, man. All right. Any questions there?
So you just pulled your arm back.
Mm-hmm. Just scooting toward the edge, letting the arm drop over the table. It's a nice little stretch. Okay. Again, elbow extension is usually the range that will be needed. If I needed to add flexion, I could. Start with elbow extension with them lying and flexing up and down. That works very well. Wrist extension is a direction you're going to need more than wrist flexion a lot of times. So I can have them pronated like so, and then just move the wrist up and down. And you can do this while you're just standing there. So we want to move the wrist into flexion extension. This is wrist flexion extension. Also, don't forget the wrist also has abduction adduction motion that we call radial ulnar deviation. So you also want to move the wrist in and out. So don't just forget about the flexion extension. Also get the radial ulnar deviation. And then the fingers, usually fingers the best direction for those. They usually will get stiff with fisting, so people will want to fist. So you want to move them into more extension. And then you can take them into flexion, moving them into extension, moving them into flexion like making a fist, extension, flexion. Okay? All right. Any questions there? Make sense? Good stuff. Okay, so that's upper extremity. That's all of the directionality except for pronation, supination. Yeah, about that. My apologies. Don't forget pronation, supination. Having the arm still resting into the body. Rotate the arm around and down. So that's supination here. Bringing the arm up like this, like you're holding a bowl of soup. And then think about pronation. Think about going pro playing basketball. So your arm is down like this to dribble. Pronation, supination. So, good way to just think about those. And that's all of the range of motion for the upper extremity. So a way that I'll demo it so that you can just see how fast it goes. It's not something that should take all day when you're going, God, maybe for 4 hours, just moving somebody around. This is ridiculous. So it's not that. So I come in, good morning, how are you today? Wonderful. I'm going to move your joints through the motion, okay? You just hang in here with me. We're just going to go have a little bit of fun. You make small talk. How are you? How are your grandkids? Does anybody come to visit you? How's lunch? They serve you anything worth eating here? It's going to be a great day. I really am excited that today is a good day. Whatever small talk you want to do. Sports fans, you watch the game. What do you like? What's your favorite team? What team do you hate? Most people will tell you they hate one of them.
That's true.
Range of motion. Pronation, supination really quickly. Wrist extension, flexion. Okay. Then we go into radial ulnar deviation, moving the wrist. Wrist extension. And then I'll close it out. Scoot a little toward me here if you don't mind. Close it out, dropping the arm off, get shoulder extension. And in that minute and a half, we've walked her through all of the different ranges of motion of the entire upper extremity. You can do as many repetitions as you like, but it doesn't have to take forever. It's something you can do really quickly.
When you put your hand here, when you're doing the thing with arm back and forth like this, is that, like, when you're saying that it can pop out, is that why it pops every time?
It's the tendon is rolling. So you're just getting a tendon roll. Weird thing. Shouldn't be doing it, but usually that tendon roll you're feeling doing that, some tendon is uncomfortable. That's actually the head of the humerus. Moving back and forth in there, so it's uncomfortable. So it needs stability. So we're locking down. Yeah, so it's clunky for some reason. We have to take a look at why. So not sure why that was clunky.
So it's not supposed to do that?
No. same as upper extremity. Same concept on lower as we would do with upper. Staying near the person, keeping close to the body. With this one, you will ask them to change positions. It's going to be valuable that they change positions. Yeah, there we go. Here, still. Okay, so this one, it's going to be beneficial to have them change positions, especially when we're doing hip extension. It's going to be more valuable, but we'll walk you through the different motions of the hip, the knee, and the ankle and foot. So the motion for the lower extremity comes from the hip, the knee, and then the ankle, foot, toes as well if we need to do that. So hip and knee, one of the first places we'll start is just holding the patient's leg. Again, I don't want to be way out here grabbing somebody's leg, going, we're going to just throw that leg in the air. Stay near them, hold on to them, walking up. In this motion here, you're stretching hamstrings, moving into hip flexion. So I'm stretching the hamstrings, back of the leg. I'm moving into hip flexion with knee extended. So that really stretches all of the hamstrings because the hamstrings attach to the hip and below the knee. So that's a good motion for hamstring mobility to stretch that, but it's also moving her into hip flexion. I come down, I move right into a flexed knee, and then I walk her into hip flexion this way. This is a stretch for the gluteus muscle, gluteus maximus. So this one's more hamstring, a little bit of glute. This one is strategically for the glute, stretching the glutes. The glutes get really stiff because you're laying on them most of the day. So I'm just holding the leg still into my body and just trying to push. You don't want to push straight up toward the eye. You want to give it a little bit of abduction and push more toward the shoulder because that's going to clear the hip and allow it to move easier. This is a lot more uncomfortable than this. Make sense? Okay? So you want to push that direction. So that's flexion of the hip two different ways. And both are needed. Both are needed when we're doing range of motion. From there, I do internal, external rotation of the hip. There's a number of ways you can do this. It can be really active for your patients that can tolerate it, where I am holding the leg towards me, and I'm holding down by the lower portion, the tibia portion of the leg. If I walk her leg out this way, so I'm not yanking it out, I'm not fighting her. We're not muscling her. We're just rolling her leg as far as it'll go. That's going into internal rotation of the hip. So this is hip internal rotation. And all I'm doing is, again, using my body. You'll see my trunk doing the rotation and not just my arm trying to do this. So my arm is holding, my trunk does the motion, supporting. Okay. Then I can move her, switch my arm position, coming here, and grab onto the opposite hip and move her to external rotation. Still just transitioning motion. Nothing aggressive, nothing painful. Transitioning motion. So if the patient can't tolerate that, the more active stretch, then I can do a more passive stretch that's still just as beneficial, but it's a smarter way of doing internal, external rotation. So what I will have her do is keep her knee flexed, scoot a little bit toward the middle foot. No. So you right. Okay. So I have her keep her knee flexed, and now by positioning her foot and moving the leg, I'm still able to get internal, external rotation. So if I keep her foot in neutral and I move her leg out and in, that's just ab and adduction. Abduction coming out, adduction coming in. You agree? Good. I agree too. So, but now if I take her foot and I slide her foot lateral to her knee, and now I roll her hip in. I'm not doing adduction anymore. I'm doing adduction with internal rotation. See how her hip is actually rotating down and in? It's not just coming toward the midline anymore. It's a rotation toward her opposite knee. So now I'm doing hip internal rotation. And that's changing what she actually feels in the motion. Great. So it is a difference. And the only thing I've done is reposition her foot lateral to her knee. And now I'm able to turn this into internal rotation. Holding down on the hip here, rolling the leg in, that's moving her into internal rotation of the hip, instead of it just being adduction. Same thing, if I want external rotation, I move her foot medial to her knee, and now I let her leg drop out, and that's now external rotation with abduction because of the position of the foot. So by switching the position of the foot, I change the functionality of the motion. That's something easy to do. Really, all you're doing is moving the foot in or out. And that changes the function of a motion that we normally would do for ab and adduction. We now convert it to internal external rotation. And patients love this. This actually feels pretty good. Because most times patients are going to lay in bed with their legs abducted, externally rotated. This is how your patients lay all the time. So their hips get really tight because they lay there like this all day. So one of the first things I do when I come in is just get their hip moving into some internal rotation. Lateral the foot, holding the hip, and I just start to stretch, and they go, oh my gosh, it feels so good. My hip's been needing that. I didn't know why my hip was hurting, baby. Like, yes, ma'am, I know. We just, you're a genius. No, ma'am, I just studied kinesiology and understand movement. But, thank you. So, not a genius. You do understand how the body moves. So, just think about the position that you're going to be in all day. It's going to look like this. So that feels great. And I don't have to get the leg up where people feel uncomfortable. I can keep it on the bed and still get the same functionality out of it by using the functional movements of the hip. Okay? So if I wanted just pure ab and adduction, I bring the foot in neutral to the knee, line it up vertical to the knee, and now when I roll my hip out, that's more abduction, just pure abduction. If I roll my leg in, that's pure adduction. Or I can bring the leg down and walk into ab and adduction as well. Just walking the leg out and in. Same way. Okay? With most of these, by having them move their knees up and down and positioning them, you've already done the function of what the knee will do. The knee only flexes and extends. Doesn't have any other functional motion. Well, it does. It has a little bit of rotation at the end, but it's an accessory motion and not a primary motion, meaning we can't reproduce it with anything we're doing here. It just has to happen as a function of moving the knee. So that movement happens through that. But we can passively do it as well if we like. Support over the knee and push all the way with it when we get full flexion. That's certainly a way we can do that as well. Foot and ankle, for the most part, patients are going to lie in the position she's in here, with the ankles relaxed and plantar flexed, down with the ankles pointed down. We want to kind of help pull them out of that. So one of the things we would do, so one of the things you would do, if you don't like feet, some people are not big feet fan, but what I love to do, you can drape a towel over your shoulder and just get the foot into the shoulder. So instead of you trying to muscle it, standing here, push it up, that's gonna wear you out. Use the force of your body. So I get her foot into my shoulder here, so my shoulder is doing the work. My shoulder takes up the slack, and now I lean in with my body. So I'm not doing the work with my hand or my fingers, my body weight does the work. And so now my stretch is more complete, and she actually feels the stretch there. Producer. And you can add as much or as little force as you need so that you can start to stretch the calf muscle, because the feet naturally want to stay in that plantar flex position throughout the day. I just hold this. This is actually a long range stretch that I love doing with patients. 30 seconds to a minute, just holding it in this position, letting the stretch happen and easing on. Make sense? And then the last one, you can do foot and ankle things if they need them. Usually toes will curl, so just like the wrist, they need to be moved into extension. And then if they're able to tolerate it, have them sidelines. Roll into your right side. And we do hip extension from here. So what you want to do, support the body with your body. So I'm not standing way back here holding the leg. I support the body with my body. I'm going to hold here under the knee. And then I'm just going to walk her back in extension. So I'm just walking back in extension. Same thing. Body does the work. Not doing the work through my arms. My body does all the work. If you lead with your body doing all the work, you won't leave feeling like you died that day. So you won't leave out the room going, God, I just need an hour just to relax. I'm so tired. It just wore me out. So it won't wear you out. Your body does the work. It's meant to move things. It's meant to create force. Your hands and arms are going to wear out quickly. Your trunk is meant to deal with things and do it consistently throughout the day. Okay? Any questions?
Well, first of all, I'm jealous that I didn't volunteer.
I know.
Okay?
Me too, actually.
Dr. Winston, what if you have a patient that has a contractured foot?
Good
Okay.
question. Okay.
Because we see a lot, sometimes.
Foot contractures are hard, depending on what's going on that's causing it. So, if they're contracted into plantar flexion, diagnosis matters most. So let's say we have a patient who they're just bed bound. They don't have a diagnosis that's forcing plantar flexion. So they don't have traumatic brain, they don't have stroke, they don't have any of the conditions where there's a neural connection forcing plantar flexion, but it's just the fact that they're lying all day in a dependent position and the feet are starting to plant down. For that patient, all they really need is proper position. So there's a couple of things we can do with that patient. You can order dorsiflexion boots, or the thing I like to do is tell the family, go to Walmart and buy a pair of shoes that lace up beyond the ankle. So they can't be low top shoes. They have to lace up above the ankle. So a mid or a high top shoe, and tell them to lace the shoe up and let them lay in the bed with it. It actually forces dorsiflexion without you having to do anything. Anybody here with a mid shoe on or boot? Shoe or boot? Boots. I saw you. I was calling you. Okay, I want to switch for a second. You know I come on down. I promise you I'm not. Yeah, you're good. Okay, so jump on here for me. I'm sorry. I need to clean it for you. So let's prove a point. So naturally, when you lay, so that, mind if I take one of your shoes off? Okay. So I'm gonna do her left foot or right foot. Right is right. So her right foot, take her shoe off. Now, it's really easy laying here without your shoe on to have your foot like this, isn't it?
Yeah.
Naturally comfortable. But what do you see here?
Her other foot is like,
Straight. No matter, she'd have to work to push the foot down on this side because the shoe is doing the work of forcing dorsiflexion. So I tell people this all the time with their loved ones. If they can't go home with the dorsiflexion boots, they don't have the money to order them. I tell them all the time, go get a pair of cheap high top shoes from Walmart and let them sleep in them. And they're gonna look at you nuts. They're gonna go, what? Same way your faces looked at me like I was crazy. The dumbest fellow I've ever seen in my life. That doesn't work. Until you see it, and you go, crap, he's actually smarter than I thought he was. So that's one thing we can do. If it's just a patient is lying in bed, and it's just a dorsiflexion weakness because they are not very mobile, but there is no neurological condition fighting against it. If it's a neurological condition, they're going to need those dorsiflexor boots. You're going to need something to fight against it because what they're starting to develop is spasticity. And they're going to become spastic, which will lead to contracture where the foot is constantly fighting into plantar flexion. So it's not a muscle imbalance or weakness from just prolonged lying. It's actually now being caused because neurologically the plantar flexors are constantly firing and there's no balance between the muscle innervation and inhibition, meaning the dorsiflexors or the muscles on the back of the leg aren't wanting to turn off to allow for the foot to go into dorsiflexion. So, the plantar flexors are constantly on and firing, and they won't even allow for the foot to go into dorsiflexion. Those are going to be the patients that absolutely have to have the boots. Another thing that you can do, they may be uncomfortable, especially if they're in a hospital bed, slide their trunk down toward the edge of the bed and allow their feet to brace up against the foot rail. And that will force dorsiflexion some. It helps to even fight some of the clonus. Clonus is the motion where once the foot goes into dorsiflexion and it's not used to it, you'll see the foot do the rapid motion like so. That's called clonus. Sustained hold helps with clonus, and that allows for it to relax over time. So they'll need the dorsiflexor boots, and I would also slide them down toward the edge of the bed so that their foot braces up against the footboard to allow that clonus. It'll have a clonus for a few seconds, but it should relax and it'll allow the dorsiflexors, it'll allow the plantar flexors to get a stretch, putting the ankle back in neutral. Those are a couple of suggestions I would have. So for the most part, for your patients who are just weak, who just have been in the bed for way too long, and because they're lying too much and they're not getting up, and they're starting to get that plantar flexion of the foot that's uncontrolled, and they're not getting active dorsiflexion, stick them in a boot or high top shoes. Life changing. It really is. Cheap pair of shoes can save the foot in neutral. And so we see it's pretty cool. Thank you for wearing cool shoes today. So, any other questions? Now you're in motion. All right, we'll take 3 or 5. Let's take 5. Stretch your brains, and we'll come back and we'll do some transfer training. Showing you the skill of how to transfer almost any patient on this side of it. Nobody believes it. Like, you're lying. You're not going to do it. Teach you how to transfer any patient just about on this side of it.